here almost always ruptures, and this rupture can be seen both here at the patella, but also at the femoral condyle side. And by experience, we know that the MPFL heals poorly, especially if there's dysplasia present. And 2/3 of the patients with instability have this dysplasia. So this is probably the most common reason for having a chronic instability. And that is seen in 20% of patients after primary dislocation. And if a patient has a second dislocation, then we know that more than 50% of these patients will have further instability. So this is when you need to have reconstruction done, not to have continued instability. So the anatomical factors that are important for patellar instability are both soft tissue, the medial stabilizers, the MPFL, patella aorta, and general hyperlaxity. The bony stabilizers, or the pathology that can cause instability, is dysplasia at the trochlea, at the patella, but also femoral anteversion can add to the risk of having instability. So the medial stabilizers, the MPFL ligament, as you see here, a little bit of the anatomy. So this inserts at the proximal 1/3 or 2/3 of the patella here, and some of the fibers fuse with the VMO aponeurosis, as seen here. There are some important landmarks for reconstructions, as Peter mentioned. The abductor manus insertion area, we have a tubercle that is very easily palpated, and that's a very good landmark for your reconstruction, because as you can see, if you go slightly anterior and 7 millimeters distal, there you have the insertion area at the femoral condyle. So this is what you want to create. So the biomechanical consensus of soft tissue stabilization is that the MPFL is the primary restraint and provides more than 60% of all the soft tissue restraint to lateralization. The previous concept that lateral patellar retinaculum had anything to do with the lateralization has been shown not to be true. So the lateral retinaculum does not pull in the patella. So that's why lateral release as a treatment for instability is now obsolete. Other soft tissue issues is patella aorta, as seen here, and that is probably a developmental condition where if you have a high patella as a child, the patella is not working correctly in the trochlea, and that could be a reason for getting dysplasia during childhood. The bony stabilizers are the configuration of the trochlea and patella, and here we see a normal joint and the dysplastic joint, and the dysplastic joint is characterized by a flat trochlea, which is only articulated with one of the patella, the lateral patella facet. But also the femoral version can affect the patella stability. As seen here, if you have increased anteversion, then the patella will be lateralized by the pulling of the muscles, and you will have compression. So typically these patients actually more have cartilage and pain problem than instability. There are numerous radiological investigations that you can do to characterize patellar anatomy. And sulcus angulus, describing the angle at the trochlear sulcus, is one of them. Trochlear dysplasia, patellar dysplasia, the lateral tilt, T to G distance, and patella aorta indexes. So the trochlear dysplasia is typically characterized by the de Schuur classification, where a type A is a trochlea with an intact sulcus but decreased. A type B is a flat sulcus. And a type C, you have a dysplastic medial condyle. And in type D, you have a convex trochlear surface. And in the 2 severe degrees, the C and D, you get the bony bump, which causes, in many cases, a maltracking. Another measure of trochlear dysplasia is the lateral trochlear index, which is the angle between the posterior aspects of the condyle and then the lateral facet of the trochlea. And more than 11 degrees is considered pathological. The patellar dysplasia, characterized by Viberg, where in dysplasia we see a shorter and more steep medial facet, as here, that doesn't articulate in the joint. What has been suggested as an important parameter for lateral vector, muscle vector forces is the tibial tuberosity trochlear groove distance. And this is the distance between the most prominent point of the tibial tuberosity and the deepest point of the trochlea. And this distance can be, if it's more than 15% and more in males and more than 20 in females, then it is considered pathological, and it's frequently used to indicate the need for a tibial tuberosity transfer. Patella also can be characterized by different indices. The inside salvati is the most commonly used, and that is the index between the patellar tendon length and the height of the patella, and more than 1.5 is pathologic. Another is the French Canton-Duchamp index, which is an index between the distance from the inferior cartilage edge of the patella to the tibial plateau, and then the cartilage edge length of the patella. Here 1.2 above is pathologic. In a large cohort of patellar instability, it was found that dysplasia, severe dysplasia of dissured CAD was found in 1/3 of the patients. So it is a very prominent element of instability to have dysplasia. And here we see a very important clinical sign indicating severe dysplasia, the positive J sign or inverted J sign, where the patella needs to get past this prominent bump of the trochlea before it can get in. So the surgical treatment strategies for patellar instability should correct the pathoanatomy. So the MPFL reconstruction is done to recreate the medial soft tissue restraints, a tibial tuberosity transfer, to redirect a lateral insertion of the patellar tendon, and a trochleoplasty to recreate a severely dysplastic trochlea. So there are so many reconstructions types being described in the literature, and the principle for all of them is that you add tissue from the medial side of the patella to the medial femoral condyle, and these have actually all excellent outcomes in the studies that have been done, with redislocation rates of less than 5%. But there's no studies that have suggested that any technique is better than another. Tibial tuberosity transfer can be either straight medial, as we saw by Weiner a little bit ago, but it can also be anteromedializing, as described by Folkersson, where you have an oblique incision, and then when you medialize, you also anteriorize the insertion, which can offload patellar lesions, cartilage lesions. So that is an indication for doing this type of osteotomy if you want to offload cartilage lesions. And then it can be a distalization if you have patella alta, as seen here. An indication for distalization, patella ulcer, but this also is good for maltracking because it gets the patella earlier into the sulcus, even though it's dysplastic, and can in many cases treat maltracking. Trochleoplasty has been actually known for many years, but it's not widespread because it's major surgery and not easy to do. But it was described as early as 1915 with an elevation of the lateral facet, but it was more popularized by De Schuur, by this deepening trochleoplasty, where bone is removed under the articular surface, and then a new sulcus is created. More recently, arthroscopic technique, as seen here, has been described by Blum. So where it's actually possible to loosen the cartilage arthroscopically and fix it with resorbable tapes, as seen here. So an algorithm for correcting the different anatomical abnormalities seen here. If you have insufficient medial retinaculum, which is a more frequent pathology, we do an MPFL reconstruction. If you have a lateral tibial tuberosity with and without cartilage injury, you do a medial or an intromedial tibial tuberosity transfer. If you have maltracking and patella alta, you can do a distalizing transfer of the tuberosity. And if you have severe trochlear dysplasia, grade C or certainly grade D, you should consider also doing a trochleoplasty. But since many of these pathologies are present in the instability patient, you often end by doing a number of these procedures in combinations. Thank you.